All right, this is an injury while operating a skid steer with a bucket in front of it. And the mechanism of injury is you're turning the skid steer from left to right as fast as you can. You're in a hurry, you're building a building or excavating. And when you turn your head to the left as far as it'll go, that's what you do when you turn the steer to the left. You're bumping up and down, shaking back and forth, hitting boulders and things, and then you're going back and forth. And while you were doing that, all of a sudden you had this thing come on you like you were having a stroke. You felt drunk, you disoriented, vertigo.
Yep, ataxia. Severe disorientation.
Disorientation. All right. So did you go straight to the emergency room? The wife is a nurse, so you did a neurological exam on him right on the spot.
Yep.
They called you first?
Mm-hmm. Yeah,
okay.
I did.
And you worked him up like you had a stroke of the brainstem.
Well, I did the Cincinnati scale on him,
mm-hmm.
and he didn't have any unilateral deficits. So I wasn't originally thinking that, stroke. It wasn't until later, after we kind of got down a couple of years of doing research and whatnot, that I discovered that a stroke to the brainstem usually is like a severe vertigo is the initial onset.
And right when my onset happened, it was right at the height of COVID, so it was kind of one of those stay home unless you're dying kind of things, but I didn't necessarily feel like I was dying. I just felt the extreme vertigo, and I mean, it was disorienting, and I just didn't know what it was.
Okay.
Yeah.
Well, we're 2.5 years out now. You've had MRIs, CT, you've had the whole workup by every doctor, and you're flying him all over the country to different specialists. Okay. So what it turned out being is that you have a couple of vascular anomalies, you have other anatomical anomalies that are within normal limits until you get injured like this. So here's what we found. Well, the anatomical variant is that you have a dominant right vertebral artery, very large on the right, wispy on the left, large, wispy, all by itself, doesn't matter, doesn't mean anything. People are asymptomatic with this all the time. It just plays out when you get injured. You got a rotational injury. So here you can even see how the right vertebral artery goes across and pretty much bisects the spinal column or spinal canal. And here we see when you turn your head to the left, the atlas comes off of C2 quite a bit, but not too much. And the big thing is that we see the skull rocking off the C1 significantly. As a matter of fact, it rocks so far it only stops pretty much when it's bumping into the odontoid process of C2. Here it looks like there's a little space in there, but it's the tissues are compressed, and that's what's stopping it there. Now on the other side, when you turn your head to the right, it does the same thing. Your skull is sliding off out of the atlas, and it does absolutely bottom out against the odontoid process of C2. So we see a hypermobility in here, and of course we have a vertebral artery, this coming across. So far, it's actually called a Dolichoectasia at this point. And when you turn your head to the left and the right, this artery is being tractioned and pulling into the spinal cord or brainstem at this level and away. And actually we can show that to you on what the MRI looked like there. I'm going to pull it up on this screen here. So there's the Dolichoectasia of the vertebral artery. You can see how it's indenting and putting pressure on the brainstem. Now, we see this a lot, and it doesn't matter. It's dormant. It's not causing any symptoms. But when these Dolichoectasias become active and symptomatic, that's when you're going to have a lot of symptoms that just come across like a stroke, and it's a little confounding there. So this vertebral artery was being pulled across even more because of the hypermobility Just to make that clear, this vertebral artery runs through the artery, through the atlas. So when this hypermobility occurred from your rotational injury, left, right rotation as far as it'll go, it's called a closed pack position, the way you were, and then the forces went through during rotation. So you are taking this vertebral artery and tractioning it, probably causing an irritation to the artery in itself too. Not to mention the waveform that goes through there, the throbbing and pulsing of this artery plays out. So you've indicated that your whole life, when your heart rate gets up, you'll have funny little symptoms sometimes that don't make any sense, but your heart rate goes back down and it just goes away, and it's not the kind of thing you seek medical care for. I mean, you marry a nurse, maybe that was for one of the reasons you married her. So you have this anatomical variance where C2 is attached to C3, and it does a scalloping thing in here. So here we're seeing the joint capsule and the transverse ligament that goes around the odontoid swollen and occupying space. So that thing is all beat up, and you can see how this is the cerebrospinal fluid that flows through there. And the radiologist that read your MRI of flexion and extension that you did about 2.5 months ago, that radiologist did a wonderful job trying to describe the mechanisms and the phenomena and how this plays out when trying to make measurements for instability at the cervical cranial junction. So because of this anatomical variant, you have excessive forces going below it and above it. So when you whiplash and injure yourself, it doesn't the energy is not dispersed like it would be if this was an actual disc. So that really did focus your injury at that level. Here's another shot of it. We have a wispy vertebral artery on the left, extra calcification there, some other little anatomical variants. This is a beautiful still picture of how far you slide off left versus right. Now that C2 is also high on one side, causing the atlas to tilt up to one side. Today we adjusted you. We measured the atlas to be high on one side, 4.5 degrees. We adjusted it, it came down to 2.5 degrees. So we expect that cerebrospinal fluid flow to be less turbulent as it goes through here. We've put you in a cervical collar. We don't want you to move this anymore. We're going to send you to some doctors that are going to stabilize this thing. There's a little calcification of that C2, C3 from the excessive wear over time, and that is going to again foster turbulent CSF flow as it goes through there. So we expect the spinal cord to be shaking aberrantly. The brain could even be shaking aberrantly because of that. We did find your hyoid to be crooked and twisted to one side a little bit. This injury that you have has some contractures in through there. Here you can see the injury between C2 and C3, how it's over time it has not been loading correctly and wearing out unevenly. Some spinous anomalies there. Another shot of that. Here we are showing the ranges of motion. There's a good shot of that hyoid as it's not sitting correctly. And we did try to align you because we care about cerebrospinal fluid, we care about vertebral artery flow, care about a few things here. Another shot. There we go. Oh, so the radiologist that did the imaging, I mean, he did an amazing job writing that report, trying to describe what he saw. And we'll leave that on the screen for a moment so people can read that. We got more of those. Right, so he took measurements of you flexion and extension, showing some instability, but not all the measurements were pathological, indicating instability. Whoops. The way we normally see it with a flexion extension injury, because your injury was rotational. And we'll let that stay there. Okay. There's a shot of you in flexion. You've got this anatomical variant that really does play out when it comes to cerebral spinal fluid flow and any turbulence in there. Beautiful shot, flexion extension. Okay. Any questions?
No.
I don't think so.
All right, thank you very much.